Connected by purpose, driven by passion. Welcome to the Spark Live webinar series, where we gather to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities. Keep up to date on all of Children's Healthcare Canada's webinars, events, and announcements. Sign up for our Spark News e-bulletin by visiting our website at childhealthcan.ca and follow @childhealthcan on Instagram, X, and LinkedIn. Now, on to today's webinar.
Hello, everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series, a service to our members, strategic partners, and the child health research community. I'm Paula Robeson, your host for the next hour. I'll begin by acknowledging that Children's Healthcare Canada operates on the traditional and unceded territory of the Algonquin and Anishinaabe peoples. We recognize and deeply appreciate their historic connection to Ottawa. Today, Ottawa is home to Indigenous peoples from across Turtle Island. Children's Healthcare Canada is committed to working toward forging new and deepening existing relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land as we work to measurably improve children's health outcomes from coast to coast to coast. We're delighted to speak today with colleagues from the Popcorn Network, Dr. Nadia Remuliotis, Abby McCluskey, and Dr. Holly Agostino, and they're sharing today COVID-19 restrictions and the surge in eating disorders among youth in Canada. Before we begin, we invite you to answer a few quick poll questions for us. Please note that you'll have to answer all of the questions to submit your response. And while you're responding, and thank you so much, this helps with our evaluations, I'd like to introduce our speakers for today. Dr. Nadia Remuliotis is a pediatric intensivist and clinical scientist at Saint-Justin. Her research projects funded by CIHR and FRQS focus on the critical care safety systems, including medication and discharge safety. She holds a PhD in clinical epidemiology and health services from the University of Toronto, during which she acquired expertise in health administrative data sets. She's part of the Canadian Pediatric COVID-19 platform, Popcorn, where she uses administrative data from the Canadian Institute for Health Information, or CIHI, to evaluate indirect outcomes of the pandemic on youth. Abby McCluskey is an individual with lived experience of an eating disorder who's passionate about using her experiences to advocate for change within the healthcare system, particularly related to child and adolescent care. She's in her third year of a Baccalaureate of Health Sciences program at the Queen's University, but grew up in Victoria, BC. Over the past year, Abby has been involved with Popcorn as an advising capacity, using her lived experience to help guide research interpretation. Dr. Holly Agostino is a member of the Division of Adolescent Medicine with the Department of Pediatrics at the Montreal Children's Hospital. She completed an academic fellowship in adolescent health and is the current medical director of the MCH Eating Disorder Program. An associate professor of pediatrics at McGill University, Dr. Agostino is executive member of the Royal College and Canadian Pediatric Society's National Adolescent Medicine Committees. Her current academic and research interests center around the medical management of eating disorders and the delivery of confidential and effective patient communication in the tertiary setting. Welcome all. It's now my pleasure to pass the mic to Dr. Nadia Remuliotis.
Thank you very much, Paula, for that lovely introduction. I'm delighted to be here today, and thank you to Children's Healthcare Canada for allowing us to present today. I'm here again with Abby McCluskey and Holly Agostino. So we're going to talk to you a little bit today about some study findings and then some lived experience and then some management and what's going on right now with eating disorders. So I first want to talk a little bit about Popcorn. Popcorn is a national network that brings together clinicians, researchers across a pan-pediatric network. Next slide. And this was really created in response to the COVID-19 pandemic. And the platform really provides an infrastructure to evaluate indirect consequences of what happened during the pandemic, but also an infrastructure for future pandemic preparedness and prospective studies related to pandemics. It is a CIHR-funded initiative by Carolyn Quash, and this particular study is also funded by the Observatory for Children's Health in Sylvana Cote, and the researchers that helped with this project and co-led it are Matt Caruana and Quintone in BC. The network brings together 16 pediatric tertiary care centers across Canada to provide really pediatric expertise on this pandemic preparedness. So I'm grateful to them for that. Next slide. So a bit of a brief introduction. We have to mention and underline that Canada really outperformed many of the G10 countries in terms of its response to COVID-19. And I say this because if we look at a graph to the right, Canada was really amongst G10 countries, one of the countries that had the least amount of COVID-19 hospitalizations per million people, the least amount of COVID-19 deaths per million, and one of the largest countries with the proportion of population receiving 2 doses of the COVID-19 vaccine. And it was really beat only by Japan. And so this was published in the CMAJ, but it had a high cost. So the cost of this was that Canada was the second most stringent country amongst these G10 nations, surpassed only by Italy. If we talk about stringency, what does stringency mean? It really means we had really restrictive public health measures. And these public health measures can include school closures, restrictions on gathering, and restrictions on travel. And the stringency index, which was used by many, many countries across the world, really measures this restriction and this stringency of public health measures. And it runs on a scale from approximately 0 to 100. And you can see that here in the graph here. So we had very, very stringent measures. Next slide. And what that meant was that by the end of 2022, the average Canadian child missed 51 weeks of in-person schooling. And so we surmised that this really had a profound impact on youth across the country, and that there were likely mental health impacts related to having missed so much in-person school, but also all of the peer interactions that come with restrictive policies. So we designed a study. So our initial study looked at evaluating mental health hospitalizations across the pandemic. Next slide. We used cross-sectional data from the Canadian Institute for Health Information and INES, which is in Quebec. And we wanted to estimate the difference in hospitalizations after the pandemic compared to before the pandemic across different mental health disorders. And so the mental health disorders we evaluated are listed here: anxiety, mood disorders, eating disorders, personality disorders, and suicidal ideation. We looked at children and youth that were aged 6 to 20 years of age, and we looked 4 years before the pandemic and 3 years after. So next slide. So what did we find in terms of results? You're looking here at a forest plot, where on the right side of the forest plot, there are more hospitalizations in the post-pandemic period, and on the left side of the plot, there are fewer hospitalizations in the post-pandemic period, and you have the diagnostic subgroups on the side. And so what's really striking here is that for eating disorders, both in males and females, there was a large increase in the proportion of hospitalizations after the pandemic. So the incidence rate ratio was much higher after the pandemic, both in males and females. Next slide. So that really gave us the idea that restriction may have been associated to this. And then we proceeded with a second study where we wanted to evaluate the association between eating disorder hospitalizations and stringency across the country, public health stringency related to COVID-19. We connected a second study where we did an interrupted time series, which means that we cut time periods into 1 month aggregate periods, and we look every month at the amount of people that are hospitalized for eating disorders. Because this is a rare condition, we actually had to aggregate the country into regions. So we aggregated them into the regions that you see there: BC, the Prairies, Quebec, and Ontario. We had insufficient numbers to include the territories and the Atlantic provinces in this study. And we looked at youth who were 12 to 17 years of age. And again, unfortunately, because this is a rare disease, in the male population, we didn't have enough aggregates to look in males. So this is specifically looking at females 12 to 17 years of age. And we looked at hospitalizations with related to stringency index, used the Bank of Canada index. Next slide. So what did we find? Here we're looking at interrupted time series for the 4 regions that I mentioned. So Quebec, Ontario, the Prairies, and British Columbia. And what you see in the wiggly yellow lines is that the incidence rate of hospitalizations per 100,000 people before the pandemic, and then after the gray bar, you see what is expected in the post-pandemic period. In blue, we actually see the amount of hospitalizations that happened, or what we would call the observed hospitalizations in the blue dots. And we can see that across regions in Quebec, Ontario, Prairies, and British Columbia, the blue line exceeds, the blue dots exceed the yellow line. And so there's far higher amount of hospitalizations after the pandemic. What you see in the blue shaded area is actually an overlay of the stringency. So you can see that Quebec and Ontario have higher levels of stringency, and the scale is on the right-hand side with a heat map that we're showing in the top right corner that show that Quebec and Ontario have sort of hotter red and orange zones of stringency over the course of the pandemic period. And so when we overlay that, there's a strong association between hospitalizations and stringency. And that is expressed in a model that I'll show on the next slide. And so when we look at this model, we modeled the hospitalization rate with regards to stringency in the post-pandemic period. And we saw that for every 10% rise in stringency, there was a 5% increase in hospitalization rates for eating disorders in Quebec, in Ontario, an 8% rise in hospitalizations in the Prairies, and an 11% increase in British Columbia after we adjusted for these covariates. Next slide. And so this translates into when we look at what was observed over what we expected, we see that there was actually in the first year of the pandemic, there was a doubling. So the rate ratio is over 2. So hospitalizations doubled for eating disorders in each region of the country in the first pandemic year. And you can see in years 2 and 3 that they remain above 1, so above what we would have expected, and have slowly come to decline only in the 3rd year. Next slide. And so we basically concluded that public health measures that were necessary to mitigate the impacts of COVID-19 across Canada were significantly associated with an increase in hospitalization rates for eating disorders in youth females 12 to 17. And of course, we suspected that this was also the case for males, but we didn't have the power to be able to conduct that for males as well. Next slide. And so why did this happen? So in the interpretation of the results, we found it difficult to understand and look at stringency and said, what elements of stringency led to this increase in hospitalization? We couldn't take individual stringency components in isolation. So we couldn't look just at school closure because these didn't happen in isolation. These happened in the context of a pandemic and restrictions on all types of gatherings and travel. And so it's really hard to know which elements associated with stringency led to these hospitalizations or were associated. We know that lack of outpatient services really led to disruptions in care and clinical management that may have led to disease progression, and that there's a higher likelihood that you were hospitalized if your disease progressed and was unnoticed. We know that youth experienced a loss of routine, peer relationships, and extracurricular activities, and an increased period of time on social media. And all of those things may have led to exacerbated disordered eating. But most importantly, it was important to find out why this happened and ask youth. And so the Popcorn Network engaged with youth with lived experience to be able to help in the interpretation of these findings and to get their views as to why we were seeing what we were seeing. And so this is where Abby McCluskey comes in, and she's a patient partner that's going to speak to her experience. I'm going to pass it over to Abby. Thank you.
Thanks, Nadia. So like I was introduced, my name's Abby. I'm currently a 3rd-year health sciences student at Queen's University, but I'm from BC. I play the fiddle, I love to read, and I'm in recovery from an eating disorder. And so I became involved in this project in November of 2023 through the initial lived experience consultation that was hosted by the Popcorn research team. I had received treatment for my eating disorder in the pediatric medical system during the pandemic, and so felt like I had insight that I could contribute when I had heard about this opportunity. While my eating disorder had its origins long before the pandemic began, I certainly attribute the circumstances that were unfolding in the spring of 2020 to how things ended up progressing. When the public health restrictions were enacted in March of 2020, my eating disorder had slowly been getting worse for months. At that point, the only things keeping me afloat was my desire to partake in the many activities I was involved with, as well as go to school. However, the onset of public health stringency measures that meant that all the things which had kept me motivated to stay well were suddenly gone. I could no longer distract myself with school or use dance as a coping mechanism. And at a time where everything in the world seemed to be paused almost indefinitely, I found myself alone with all the thoughts that I've been trying to avoid. And so my eating disorder began to consume my days, which were pretty empty in that early part of the pandemic. And I turned to eating disorder behaviors in part as a way to cope with the uncertainty of the world around me. My eating disorder had always been driven by a desire to control how I was perceived. And in this time when I had seemingly zero control of anything else, my need to control my body through food and exercise was amplified. Though I tried to keep it a secret for as long as I could, my parents began to notice that things weren't going super well, and I eventually reached out for professional help. However, as a consequence of the pandemic, all my initial appointments were conducted virtually. There are definitely benefits to telehealth-based care, but for me, in those initial stages of an assessment for an eating disorder, virtual appointments meant that the therapist and the physician that I saw weren't able to really get an understanding of how my physical health was declining at the time. It's hard to see how someone's physical well-being from a webcam on a video call, particularly because they couldn't monitor my weight and vital signs. If the physician had been able to take my heart rate during our first appointment, they would have realized that I was acutely bradycardic and met the pediatric criteria for medical instability for an eating disorder, and probably should have been hospitalized. I also began to encounter the prevailing misconception that eating disorders are primarily diagnosed based on weight and BMI. Both clinicians that I'd met with over Zoom told me separately of each other that I didn't look underweight enough to be dealing with a serious eating disorder. And because of that, neither of them felt that I needed an expedited referral to my local eating disorder clinic. Additionally, when I finally saw my family doctor in person to get the physical assessment that was required for my referral to be processed, she told me that my BMI wasn't low enough to be considered a moderate or severe case of anorexia. Instead, she proposed that I wasn't eating because I was mad at my parents, and that what I needed to do was just spend less time on my phone. However, a quick calculation of my BMI wasn't representative of my physical health or the severity of my eating disorder. My BMI failed to communicate how acutely my body was shutting down, how I spent 99% of my day thinking about food and exercise, and how I sometimes wasn't sure if I wanted to wake up in the morning. A few days after I saw my family doctor, my parents ended up taking me to the ER as a last-ditch effort to try to get some help because things weren't really manageable at home anymore. When we arrived at the ER, no one had any idea how physically unwell I was, as I'd been told multiple times by different people that I was fine, and neither myself or my parents had the experience to know otherwise. I'll never forget hearing the emergency room physician whisper to my dad, asking why no one had brought me to the ER sooner, and my dad responding that they'd been told that my eating disorder wasn't bad, and that I didn't need more advanced care. That admission to the hospital was the beginning of an extensive treatment journey, most of which I spent in hospitals for medical stabilization and later for more specialized treatment. As a result of the pandemic, my province's inpatient pediatric eating disorder unit had been briefly closed, and upon reopening, its capacity had been decreased substantially to accommodate social distancing on the unit. As well, I didn't live in the same city as the Provincial Children's Hospital, where this unit was located, and due to concerns about COVID-19 transmission, they weren't accepting patient transfers or even really doing intake assessments for anyone who was from out of town. I needed more support than the general pediatric medical unit in my hometown hospital could provide. And as the pandemic restrictions meant I couldn't access the tertiary inpatient programs, I spent a few months in and out of the hospital while I waited for a spot. Eventually, I was able to be transferred to the provincial pediatric inpatient program, following which I went to a residential treatment program before finally being discharged to my hometown's outpatient eating disorder services. It took me a few years to truly recover from my eating disorder, and my recovery was a long, twisting road which went up and down many, many times before I finally reached the other side. I was so fortunate to have had some incredible people on my care team who advocated for me to get the help that I needed each step of the way. And I really want to highlight how lucky I was to have gotten that care, because not everyone was as lucky. And I recognize my privilege in being able to access those services is essentially how I've gotten to the place that I am today, and is why I'm able to talk before you all today. Recovery has been the hardest thing I've ever done, and I hope it's the hardest thing I will ever have to do. And yet, I am so unbelievably grateful that I fought through the challenging moments to be where I am today. I'll never be able to put into words how much my recovery from my eating disorder has changed my life. I experienced the world with joy and love and sadness and freedom in ways I didn't think were possible before. Next slide. When I was presented with the results of this study that was shown earlier in the presentation, I wasn't surprised at all that eating disorder hospitalizations rose so greatly, or that these hospitalizations could be correlated with pandemic stringency measures. Notably, in the lived experience consultation group, no one was really surprised. The results were what we would have expected to see based on our experiences. For me, the pandemic created a kind of perfect storm for my eating disorder to thrive, and the study results aligned with that, as well as what I had seen occurring in the hospitals around me. When we were asked in that consultation what we thought might be underlying the unique increase in eating disorder admissions, there were a few common themes which arose from the lived experience group. And I found it really interesting that despite the vastly different histories and eating disorder experiences, we all largely agreed on some of the ways in which we thought the pandemic affected our care. This included things such as major disruption in daily routine and an increased need for a sense of control. Not being able to engage in fulfilling activities like school or social events or even hobbies can create increased need to cope, leading one to turn to their eating disorder in the absence of other coping mechanisms. It's something that I also feel probably contributes to the stringency-dependent changes in eating disorder hospital admissions. For me, a big part of recovery was finding the motivation to challenge my disordered thoughts. However, that's really hard to do when there's nothing really to look forward to. Additionally, the switch to virtual care was also identified as a contributing factor. As I experienced, the lack of physical health monitoring during the pandemic enabled rapid disease progression to the point of requiring hospitalization. In-person clinical monitoring is a vital component of care for eating disorders, which is reflected in some of the clinical guidelines that have been released after the pandemic for managing pediatric eating disorders. If severe public health restrictions, such as we're seeing in the COVID-19 pandemic, were to be put in place again, I think it's really crucial to consider the need for in-person medical monitoring for conditions like eating disorders, even in the context of pandemic-level stringency. Finally, many of us in the lived experience group felt that part of what led to the unique rise in eating disorder hospitalizations in the pandemic was the exacerbation of already existing barriers to comprehensive care, such as weight stigma, reduced capacity of treatment programs, and ineffective supports. Though these things were present before the pandemic, I feel that the sudden rise in demand for eating disorder treatment amplified these ongoing challenges, which ended up delaying a lot of people's access to treatment, and like what was mentioned, led them to require hospitalization. Though I can never know for sure what would have happened if I had received professional help when I first reached out for support, I know that the longer I spent in my eating disorder, the more intertwined with my sense of self it became. There's a lot of evidence that shows early intervention treatment in eating disorders is much more effective than treatment at later stages of the disease. And a lot of work is currently going into creating early intervention eating disorder services in Canada. However, these services haven't always existed historically, which I think is reflected in the high burden of patients who currently require advanced care. Other contributing factors identified by those with lived experience included exposure to diet culture-related messaging through social media, the destabilizing effect of global chaos of the pandemic, and the difficulties imparted by the transition between pediatric and adult eating disorder services. And while I don't have time to get into all of those here today, I really encourage you to consider the effect of all these different challenges, a lot which were based from the pandemic, and why eating disorders may be so uniquely affected. Next slide. As a final piece, I want to highlight how the lived experience consultation that Popcorn had conducted is a really great example of the value that can come from meaningfully involving individuals with lived experience in research and patient engagement. It can be a lot to go back and reflect on an experience that was really traumatic, and there's a lot of vulnerability in sharing those perspectives with people, especially if you've never really met them before. I've been involved in a few different patient engagement projects in the last few years, but what stands out to me when I reflect on this particular experience is how the Popcorn team in that space created an environment where my lived experience was viewed as expertise rather than just an anecdotal story. Through compassion and empathy and validation, they built an authentic partnership where I didn't feel like I was just checking a box for patient engagement. I felt like they were listening to what I was saying, which made such a difference. After that initial consultation, they also followed up and gave us the opportunity to translate our experiences into recommendations on what we felt was needed for change, acknowledging the value of our perspectives and experiences in doing that. What I've learned from all of this is that authentically building partnerships and working with youth can be beneficial for everyone. When I feel heard and feel like it's a space where my thoughts are valued, I feel more able and willing to bring up the hard memories and experiences which hold the insight that people are hoping for, which translates to better research and project outcomes. And for me, I've discovered that it's incredibly empowering to be able to use what I've learned from this hard time in my life to help others and improve care going forwards. Myself and the other individuals involved in that initial lived experience consultation have continued to be involved with Popcorn and this project. On the screen here is an infographic sharing the results of the study that was co-designed by one of the other youth with lived experience and was recently entered in a CHR infographic competition. For me, it's a great example of how effective lived experience engagement, though it can seem daunting and requires effort and time, can result in transformational results for everyone involved. Thank you.
Thank you, Abby, for that, and having the courage to share your story. I can't agree more how impactful it is for people to hear patients and families with lived experience, that what they've gone through and how eating disorders have affected them. So I really appreciate you speaking today. As a physician, for my section, I'm going to focus more on the clinical management of eating disorders and where we're at right now post-pandemic. Sorry. So the first thing that I want to say is that if you are working with teenagers in some capacity, then you are definitely seeing eating disorders. So even before the pandemic, eating disorders were the second most common chronic illness in adolescents after asthma. And now, as we've both demonstrated, there's been this huge surge in numbers. So what came of that more recently, that national guidelines came out of the Canadian Pediatric Society recommending that all healthcare professionals screen for eating disorders at annual health supervision visits. Because as Abby mentioned, we know that the early recognition of eating disorders and the early diagnosis and treatment of eating disorders leads to better prognosis and better outcomes for patients. It's also been shown that most youth will actually present first to a primary care or community practitioner. So it's a great time to be asking those questions and making sure that we're screening across all populations, that we don't have, checking for our own inherent biases. We're screening regardless of gender, regardless of the weight on the scale, regardless of socioeconomic background, because we know eating disorders exist in all diverse populations. So eating disorders are a challenge to treat because as a healthcare professional, you need to be comfortable treating both the medical side of the disease as well as the psychological side. And most severe cases of eating disorders do benefit from a multidisciplinary team approach and often require a specialized level of care. But unfortunately, eating disorders have been chronically underfunded and under-resourced even before the pandemic. And now we've kind of stretched an already thin system to the breaking point, which has led to extreme wait times for patients to access specialized levels of care, with wait times ranging from 6 to 12 months across the country, which is obviously unacceptable. Specialized programs have now had to put much more stringent limits on the type of patients that they accept because of limited resources. So they've had to prioritize, the patients who are extremely medically unstable or have extreme weight loss and extreme behavioral issues. And what has happened is the more quote unquote straightforward eating disorder cases have been pushed to the bottom of the list. And even as they wait on those wait lists, this bottleneck has occurred that has pushed most of the care for a lot of patients and their families back into the hands of the community healthcare practitioners. So a lot of what I'm going to talk about here in my section is coming from this recent position statement from the Canadian Pediatric Society around the community management of eating disorders. It's a great reference, so you can always come back to it if you have further questions. So the first message I really want to put out there is it's not to say that everybody who has an eating disorder or has disordered eating needs to be referred to a specialized level of care. A lot of patients will do very well with community follow-up and following with a family doctor or community healthcare professional. Patients who are followed in the community often have already long-standing relationships with their physicians, and they're in a great place to help improve the adherence to treatment. And they often will already have had expertise in coaching that family around other essential health behaviors as well. I think what's important if you are following a patient with an eating disorder in the community is knowing when they do need to be referred for either medical stabilization or into a tertiary level program, and that you're in a position to provide regular follow-up. So these are not the types of patients you can see once, see them again, 4 or 5 months later, because things shift very rapidly. They need regular routine check-ins. And even if you have made that decision to refer to a specialized program, given the wait times post-COVID, is extra important to still be able to provide that continuity of care. So I'm not going to go through this, it's in the statement, but these are the suggestions for medical hospitalization for a patient with a restrictive eating disorder. I will draw your attention to the word suggestions because it's not black and white. Not every patient who has a heart rate below 50 will automatically get hospitalized. As is the case with most things with eating disorders, it is very case by case specific. It's going to depend on the resources in your area, the capacity for outpatient follow-up, and that dynamic of that particular family as to whether patients need to be hospitalized or not. That being said, if you're a healthcare provider and you're having patients who are approaching these criteria, I think it's definitely worth starting to consider at least consulting with a more specialized eating disorder program. So if you are following patients with eating disorders, what are you going to be doing? Well, as a physician, at least, medical monitoring is really going to be the cornerstone of what you're doing with your regular check-ins with your patient and their family. So yes, assessing changes in weight, but not just that. I think it's a great opportunity, and we'll talk about this later, to assess family coping and how are they implementing strategies around the eating disorder effectively or not. Definitely evaluating for new physical symptoms, seeing if there's medications you might want to prescribe to help with those physical symptoms, and repeating any investigations as needed. Patients who are at high risk for medical compromise really do need to be followed closely, I would say every 1 to 2 weeks, and ideally you're able to bring in some of that multidisciplinary approach as well. All right, so how do we talk about these eating disorder behaviors with our patients? So it's a little different in pediatrics compared to the adult side, and I'm going to focus on restrictive eating disorders here because this is what really our research shows that surged the most during COVID. So in the adult side of treatment, we have a much more individual focus. It's more of a cognitive behavioral therapy, CBT type approach, compared to in pediatrics, where our first line therapy is something called family-based treatment, or FBT. And FBT is not a family therapy in the sense of traditional family therapy where you talk about, communication and dynamics. It's really an eating disorder specific type of therapy. But it does acknowledge that parents know their kids best, and we put parents in control of refeeding their child. And we as the healthcare team are there to support them in that journey. It's what we call an agnostic type of therapy. So we don't search for the cause of the eating disorder or, go back years and years. We're really saying, okay, we've made this diagnosis. Now let's move forward. Let's get control back around food in your home. So it's dealing with that immediate challenge of refeeding their child. And parents, a big part of it is learning to externalize the illness. So really seeing it as someone who has taken over their child and how we can get that person out of their house and back to normal relationships with food. So it is, as I mentioned, the first line treatment that we provide for restrictive eating disorders in pediatrics. And most patients who are treated with FBT will do well, depending on the study you look at. We're talking about 40 to 60% who are fully recovered at 1 year of treatment. And by recovered, it means weight restored, as well as having population norms around eating disorder cognitions, and closer to 80% at a 5-year mark. But even that, it means there's 20% of patients who don't improve with FBT. And I think that's a really important point as well, too, that eating disorders are, as I mentioned before, so patient and family specific. So, you can have the best FBT therapist, but for certain families, it's just not going to work. And that's where I think we do need to kind of have a bit of flexibility in our therapeutic options and making sure we're connecting families with the right therapy that works for them in their reality. FBT does work in 3 phases. So phase 1, parents take control of all the meals. So they're in charge of grocery shopping, cooking the meals, plating the meals, and sitting there with the teenager while they're eating their meals. In phase 2, we start to give back some control to the teenager and see how that goes. And only when we get to the 3rd phase of the treatment do we start to see, well, okay, what's left over? Is there a lot of anxiety? Is there a lot of self-esteem issues? Would this teenager benefit from some individual therapy because these issues might be interfering with their normal adolescent development? So we would say, whenever possible, referring to an FBT therapist if you have a patient with a restrictive eating disorder would be recommended. However, I say that a little bit with, knowing the reality that these resources, even in an urban center like where I work in Montreal, are very hard to come by. Ridiculously long wait times, can be expensive if you're going onto the private sector. And this was all even before COVID, right? So now almost impossible to get access to a lot of these services. But I would want to kind of coach you in the next few slides about how even if you don't have access to a FBT therapist, you can still take an FBT approach with your families. So as my kids might say, you know, TO, I'm a doctor, I'm not a therapist, I don't have time for this. But there is a lot of way you can incorporate the principles of FBT and how you counsel families when they're with you in the clinic. So it's around behavioral approaches, empowering parents to be able to set limits, and like I mentioned before, externalizing the eating disorder. And sometimes there's a lot of focus on the parents and how to make the parents feel comfortable with this. So that can seem really counterintuitive to those of us who have trained in working with teenagers and supporting their autonomy and confidentiality and all of this. So I recognize that it takes a little bit of getting used to, but it does work when the parents are able to adopt it. FBT approach, I wouldn't try it in someone where there's a history of abuse for the patient in any context, because it does set up somewhat of a power differential. The parents definitely need to be present, and being, you know, that they have to be, I'm saying parents, but it could be any caregiver, need to be around at mealtime. And it does present more challenges in older teens, the 17, 18-year-olds, where they've already established a lot of independence, and it's very counterintuitive to have parents preparing all the meals of a 17-and-a-half-year-old. Single parent homes, just because it can be hard for parents, a single parent, to be present all the time. And also in houses where there's a lot of emotional reactivity or severe psychiatric comorbidities also presents challenges. Not to say we don't try, but we're maybe a little bit more vigilant to see if this therapy is working for that family. And it's difficult for parents to stick with it. It's a lot of work. As Abby said, recovery is a huge journey. It takes so much from families, and even with the best intentions, some parents really just burn out from this type of treatment. So the first thing that I am always talking when I'm meeting with families, and I am taking that FBT approach, is that not eating is no longer an option. Food is the treatment, okay? And in the same way that parents found a way of getting in the penicillin when the kid was 3 and they didn't want to take their medication, this is the approach and the mindset we have to take now around food. Food is your prescription right now. As I mentioned, parents are in charge of all the meals, and the idea is also to progressively reintroduce foods that have been avoided in the context of the eating disorder. So we're not going to just prepare food that the eating disorder is comfortable with. We're going to be challenged in that as well too. So much of what I do with families when I meet with them is to help them build this stress tolerance. It is normal that this is going to be hard. It's normal that there's going to be a battle at every meal, especially in the first few months of this treatment. And, you know, I often will have families coming back and saying, you know, if it's going easy, there's probably not an eating disorder there, right? Because eating disorders are going to fight. They're going to look for loopholes. They're going to lash out at the people who are pushing them into the corner. And this is part of the process, and we have to be ready for it. So we recommend 3 meals and 2 to 3 snacks a day, but we don't use meal plans in FBT. We don't tell families they need X number of carbs or X number of calories. We want families to work back to whatever was normal within their homes. And parents know their child best, right? So they were perfectly fine feeding their child up until this point. We want them to get back to what was going on before the eating disorder. As I mentioned, no special food for the eating disorder, no asking the eating disorder if they'd rather eat this or that. It's again, going back to that externalization and showing families that, you know, when you're asking those questions, you're not asking your son or daughter, you're asking the eating disorder what they want, because your son or daughter is not in charge of their decisions right now. The eating disorder is in charge. Physical activity as well too. So for the physicians in the audience, obviously, if you have a patient who's severely bradycardic, or, you know, having low heart rate, low blood pressure, it's not safe for a patient like that to be engaging in physical activity. So it's appropriate in those cases to put limits around activity. But in a stable patient, I usually leave it up to the family to decide what they think makes sense for their child and for their home environment. So, you know, it's a balance. It's, if you're already struggling of what you're putting in, does it really make a lot of sense to do a whole bunch of output? And I let them kind of come to that decision naturally of what's working with their family. I think that's a big part of why FBT has the success it does, is because it's not prescriptive. It's not the doctor kind of taking over all the control and then doing all their work and then giving the child back to the family. It's about families finding real life solutions of what is working for them in their own home, in their own context. I can't stress enough how much an eating disorder doesn't just affect the patient. It affects everybody around that patient as well too. So when you're seeing a family in front of you, they might be in denial, but a lot of them have a lot of guilt for not acting sooner or not, bringing their child to medical attention sooner. A lot are exhausted. They feel hopeless. They've already tried things to get their child to eat. It didn't work. So it is important to help kind of empower them and motivate them to get back on track. I think one key way of doing this is not to minimize, right? This is not the time to say, oh, she'll get over this. It's just a phase. All teenagers don't like their body. Completely the opposite. We want to stress how serious eating disorders are. We want to stress that this can have lifelong complications if we don't take action right now. And by not minimizing or downplaying the severity of what's going on, sometimes that can help motivate the family and sometimes the patient too to get back on track with better choices around food. Again, normalizing, this is going to be hard, normalizing the expected challenges for families and externalizing the eating disorder as a common enemy. So you're not mad at your child when they throw the plate across the table, you're mad at the eating disorder. And you're not mad at your parents when they say you can't play soccer, you should be mad at your eating disorder. We need to get this eating disorder out of your home because he or she is kind of controlling everything and causing all this conflict that's there. So we talk about it being, an extra person in the house, some patients will name their eating disorder and really just talking about it as an extra person that we have to get rid of. And as I said, food is medicine, food is the treatment, and that's how the approach that we take in our clinic. So a lot of times I'll, give my speeches about the medical complications and give all that psychoeducation. And I see parents kind of turning to their child and being like, you see what Dr. Agostino said, you have to eat. Don't you hear you have to eat or your heart's not going to be sick? And they're just trying to rationalize with the eating disorder. But the eating disorder is not rational, right? And it's great when patients are there and they're motivated to get better. That's wonderful. But it's not always the case because they're not really in charge of their decisions. So we want to help parents see that and to say that they need to assume the control right now because it's not your son or daughter that you're taking the control away from, it's the eating disorder. So we use traditional behavioral modification strategies, helping, if they were able to get through a tough meal, maybe they're allowed to go to a friend's house for dinner, whatever, things like this that you can kind of find ways that work for each family. And again, resisting that urge to prescribe. Let families come up with their own solutions. You have that close follow-up. You can evaluate whether it worked or not based on what they bring to you in the next session. So it's chronic. It can take a long time. It's exhausting for the caregivers. I always feel like I give all this advice and then I realize that they're the ones who have to go home and live it. So it's important to kind of encourage families to maintain some sort of balance, do things outside of the eating disorder. Don't make the whole day about the meals and the snacks and so on too. And often parents or siblings, they need to have their own therapeutic space as well too. So we should encourage them to feel if it's needed to seek out their own therapeutic support. So just to finish up, recognizing the early signs of eating disorders, screening I would argue anytime you have a healthcare interaction with a teenager, it takes 2 seconds to screen around this. Again, making sure you're not being biased. Not every patient who has an eating disorder looks the same by any means. Know when to follow patients and when they need to be referred for higher levels of care, and providing that support to families as much as you can while they're waiting for that higher level of care as well. So I just want to finish with just a quick slide about where some other things that are going on in the world of eating disorders in Canada. So as I mentioned, eating disorders even before COVID were really understudied and underfunded, especially in the Canadian context. And we know that if we don't have good data around eating disorder, the system of care in general around eating disorders in Canada, it's really hard to make informed recommendations and strategies in either research or around clinical care and best treatment options for families. So there is a work group which is funded from a CIHR Think grant being led out of CHEO with Nicole Obeid's group that has been developed after a costing study that was done showing the huge increase to the medical system that occurred for eating disorders post-COVID. So last May, 40 or so of us met to really strategize, where can we go from here? We know what COVID has done, what can be the next steps? And we had representatives from all the national eating disorders associations. We had 9 provinces represented. There were researchers, there were healthcare providers, people with lived experience, policymakers, and so on. And really, I think the next goal, we're in early stages of this, but the next goal is really to develop databases, to get data around what's actually happening for patients across Canada. So how can we incorporate questions around eating disorders into population-based surveys that are already occurring in Canada? How can we look at metrics about what's working and what's not working, so that then we can make a more informed recommendation as to what services to get to families and provide families better access to what actually will work for them. So I have my references there if you want to consult them afterwards. And thank you. We're all very eager to take your questions now. Thank you.
Wonderful. Thank you so much for that great presentation. It's very thought-provoking. We've got a number of comments and questions that have come in. I'll sort them. While I'm sorting those out, we have another quick poll for you to help us continue to improve our program. You'll have to select all the answers before submitting your response. And while you're all doing that, I will read off some of the questions. So, related to the COVID pandemic, the public health protections contributed to the surge in eating disorders. But apart from those measures, are COVID infections themselves associated with an increased rate?
Perhaps I can take this question. I think that's an excellent question. And I saw this in the chat earlier. You know, could there be an association between having a COVID-19 infection and then having certain infections predisposed to acute neuropsychiatric symptoms? And these can be defined as PAMS or PANDAS or autoimmune system disorders that spark neuropsychiatric disease. And to my knowledge, I don't know of studies that are ongoing with that in Canada. And I think it's an excellent question, and it's an excellent hypothesis that this may exist. This has typically been streptococcal infections and things like that. But I don't think we have enough data to be able to say that for sure, but it is an excellent hypothesis. There are lots of limitations, however, to be able to study those kinds of things. And I'm going to give the example of health administrative data. So, you know, the majority of the population at this point has had COVID-19. And so then what we look at if we're looking at a neuropsychiatric system, it has to be coded in such a way that we can identify who those patients are. And so because that diagnosis is not always well recognized and certainly well coded in our hospital systems, I think that's one of the major challenges to research. And to my knowledge, there isn't, and I don't know if Holly might be able to answer that better, but I think it's an excellent question, and thank you for that.
Yeah, I agree, Nadia. To my knowledge, there's no studies looking at that right now. And, you know, in that umbrella of PANDAS and PANS and so on too, it's not something that is, well, it wasn't studied when those diagnoses were established. So it's something to definitely think about going forward for sure. But I'm not aware of any studies looking at that in particular.
As you've noted, families are impacted as well. Have you heard of or do you or would you recommend families empowering and supporting treatment of eating disorders? There's a FEAST website. Not sure if you are familiar with the program, and if so, do you use it or do you have alternatives?
Yeah, I can speak to that. We do recommend FEAST at our center. I think it does provide a lot of nice support. There's a program you can sign up for, which is free, and that provides kind of small bullets, emails sent, I think, for the first 30 days or so, and they have a lot of forums and so on that parents can connect to. That being said, I think I would hope a lot of programs also have local resources for their patients as well. The Montreal Children's, we run a parent support group because we recognize that it's helpful for parents to speak to other parents going through the same thing and learning from other people's experience and so on too. So that's been a kind of key cornerstone for our program as well. So I would, you know, if you're not already engaged in a eating disorder specialized program, FEAST is a good resource. But they are limited, and I think it's always challenging online because those websites, if they're not well established, anybody can go and leave comments on those websites, especially for patient level sites. They're not quote unquote police. So sometimes patients with eating disorders will go on, leave comments that can be triggering for other patients. So it can be very challenging as far as the recovery websites. But I wouldn't hesitate to recommend Feast. I think it's a very helpful resource for a lot of families.
Great, thank you. We've got a few families on the line who are interested in A, participating in research, and B, providing support to others with lived experience who may be earlier in their journey. Are there mechanisms for either participation in the research or in supporting other families?
Yeah, absolutely. I think we can maybe at the end of this webinar get those people's names and include them sort of in some of our patient engagement work. I know at a larger scale, Nicole Obaid's team also in the policy work has some patient partners and engaged with lived experience. And I'm sure they've done a lot of excellent research on the cost of eating disorders and hospitalizations and care. And so I think we can take those people, and I think that would be a wonderful. Thank you for your involvement, everyone who's present.
Thank you. There was a comment that came in as well around the terminology in describing eating disorders as rare.
Yeah, I'm happy to address.
Oh, go ahead.
Yeah, I'm happy to address that. I think, perhaps I misspoke. I think the outcome of hospitalizations can be less common, but absolutely eating disorders are not a rare disorder. And I think what we noticed in our research when we looked at hospitalizations is that it's really a tip of the iceberg. So having to be hospitalized for your eating disorder really means a certain degree of severity. And many are not hospitalized, and we were unable to capture the burden of eating disorders in outpatients and what was being seen over the course of the last couple of years in specialized clinics, in outpatient and pediatric primary care clinics. And so the study I presented really looked at the more extreme cases that required hospitalization, which don't happen in the majority of cases. The majority of cases are treated as outpatients, but so I meant that the outcome of certain hospitalizations, especially if we're looking at certain age groups and then certain regions and then certain sexes, it was hard to find enough cases to be able to model for the stringency association. But it absolutely is not a rare disease, and many children and adolescents and youth are at risk for eating disorders and should be screened at during their primary care visits.
That's a helpful clarification. Thanks. Is there any link between eating disorders and experiences of domestic violence? And if so, what's recommended for those families?
I think there is a link between the development of eating disorders and previous traumas. And sometimes the type of therapy might be shifted a little bit in cases where there has been a clear trauma. As I mentioned, in cases of abuse, FBT is actually contraindicated, I guess, because of that dynamic that it sets up between the patient, especially if it's a question of familial abuse. So sometimes there will be a different type of therapeutic approach in those cases. But that being said, eating disorders, there's not always this losing my word in English, but a big event that occurred where we can pinpoint that was the cause, that was the reason everything fell apart. In most cases, we have well-adjusted families, involved parents, a child who's doing well in many spheres, and there's not always I think it's a misconception that there was this big event, this big trauma that a child went through. Sometimes there is, but in a lot of cases, there's not.
Thank you. Another comment with regard to access to therapeutic options, particularly in rural and more remote areas. Are there programs that serve those communities, and does it require those folks coming down to the south for some of them?
I'll speak to us, at least in Quebec here. So we do work with some patients in northern Quebec. I think that's one of the advantages of COVID, that we've been more comfortable doing telemedicine and so on, and working with patients through Zoom or through Teams. I completely agree with Abby. I think, whenever we have the opportunity to do things in person, it's much more therapeutic. It's easy to miss a lot of the context of these illnesses when you're doing it through a screen. But it has allowed us to reach patients that otherwise we wouldn't have been able to reach by using telemedicine. So we do work with some northern patients who will do their therapy sessions with our team through Zoom, and will still need to see a physician in person because we do need to monitor their heart rate and blood pressure. And we usually will work kind of co-work together with a physician in their community. But it is a challenge. And I think one of the things we're doing in Quebec, as myself or our team and the team at Saint Justine, which is our other pediatric hospital, is trying to do outreach to practitioners who live outside of the urban area, so that they can kind of train their teams to work with teenagers in their communities as well too. So that we can kind of do that knowledge translation, so that there is a greater access for people living outside of the urban areas, because we know it's a major issue.
One comment, the final comment that I have, it's directed at Abby. And Abby, Megan said, "I just want to say how impactful your presentation was, and you're a truly amazing speaker and quite inspiring." So well done, Abby.
Thank you. I'm always honored to be able to share my story in a way that's received well, as well as that can impact and move things going forward. I think eating disorders in specific, often it's really hard to find that place of recovery. And I think a lot of the people I know who went through treatment as well, we do kind of want to run very far away from anything related to eating disorders. And so I definitely recognize there's a lot of insight that doesn't often get shared. So anyways, thank you. It means a lot to me. I'm always, again, very grateful for the opportunity.
That's wonderful. Thanks. We'll share some resources that were shared during this presentation on the website once we've posted it on Children's Healthcare Canada's website. But that's the end of our time together today. Thank you to all our speakers for sharing your time and expertise. Thank you to our audience members for your engagement and just for joining in. There was a number of comments in the chat box that you've beautifully addressed. We know how busy you all are right now, so we really appreciate you taking the time to sit in on a webinar. And we hope you depart with some practical knowledge to bring back to your organization or your families. In the weeks and months to come, we'll be hosting a few additional offerings. In case you missed it, we have a podcast on Beyond Band-Aids. Our most recent Spark conversation we hosted with Tatum Wilson from the Children's Mental Health Association Ontario. And that's available for listening right now on wherever you consume your podcasts. It's titled Collective Action and Advocacy, Coalitions and Right-Sizing Children's Healthcare. Save the date for our annual conference in 2025, taking place in Ottawa at the Westin on April 14th and 15th. Just a few months left to go for that. During that conference, the Innovation and Impact Awards are presented. Nominations for those awards close on December 10th, so get your nominations in now. And to learn more, just visit the website, children'shealthcarecanada.ca. It's always great if you watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our website. Thanks for joining us today. Thanks to our wonderful speakers for this great presentation. And hopefully we'll see many of you back here very soon. Bye-bye for now.